Hello, everyone. This is Farood Hakim. It is great to be on with Viva Learning once again. Thank you so much for attending the course, Mastering Direct Resins and Aesthetic Practice. Means a lot for everyone out there to be giving up an hour of their morning, afternoon, or evening to spend some time learning about some aesthetic dentistry using composites. We will jump into the course in just a second. You'll see on the title slide, my email is at the bottom. I'll also share it with you on the last slide and encourage everyone to ask questions at the end of the presentation. We'll review some of the questions. Any questions that don't get answered, I'm always happy to take emails from participants after the fact. So let's go ahead and dive in. Before we get into the content per se, I think it's always important for me to share some of my background with the folks attending so that you have an idea of where I'm coming from, what my dental life revolves around, and you can make a judgment on maybe my approach to things, my biases, and see which things we have in common, and maybe take what I have to say with a grain of salt. I basically wear three hats, the biggest of which is that I'm an educator. I have taught in some capacity ever since graduating in 1991, and over the years increased my responsibilities working at my alma mater, University of Pacific in Northern California. Despite that, I have always been in private practice and will continue to do so. While I've cut back, I have settled on about 2 days a week of practice, and we have a few practices here in Northern California. So I am wet-fingered and not just a textbook or type-it-on jockey. I have to make the economics work within dental practice just like everybody out there. Thirdly, and it's probably what brings me to you today, I'm a product evaluator. I've had the fortune of working with companies in dental industries and considered an opinion leader. And so that's what puts me on stage, whether it's live or venues like this, which we've had a lot of in the last year and a half, considering where the world has gone towards. I'm a member of Catapult Education. Undoubtedly, there's been other Catapult speakers on Viva Learning. If you ever get a chance to see any of these folks live or digital, I highly recommend them. We think it's a group of very talented folks. Feel free to visit our website where you can learn a little bit more about the products and the services we provide. And there is the site or the main domain page. Also, it's important to go over the disclaimer slide. Today, I am supported by Boco North America, and I will be sharing some of the products that they provide and review some of the techniques. For me, it's about the education, not so much about the product per se, but I only speak for companies whose products I do use in practice and I'm willing to pay for out of my own overhead and put on my formulary. So jumping into the course itself, the big question, do we really need another composite course? If we look at the menu of past webinars, just on Viva Learning, not to mention at every major meeting or every continuum out there, there's obviously a ton on composites. And what's one more going to do for us? In my opinion, I think it's always justifiable to learn more about composites, because the reality is these materials, these direct aesthetic restorations, are the staple of contemporary practice. We can't practice in today's arena without having resin and adhesive dentistry a principal component of what we deliver to patients' mouths to restore teeth. And so I don't think we should ever stop learning about them. More importantly, I think that they are continually developing. The era of alloys and amalgams is long gone. That technology didn't change. It was perfected. And other than very subtle variations, once you learned how to use it, there was no difference. Resins, adhesion, the world of bioactivity, there is constantly evolving new technologies out there. And so I don't think we can ever stop learning, not to mention that the techniques involved and the science behind it is very forward, very challenging. And so practitioners continue to have challenges with placement efficiency, how long they last. I constantly hear sensitivity issues. How do I make proper contact or contour? How do I get the best aesthetics? These are real life challenges that continue to persist. And so it's worthwhile talking about them. And we got to do our best, like I said, to stay ahead of the materials and understand what's out there. And certainly, I don't know of a lot of folks that are using the same composite they did 20 years ago. If you are, it's probably, time to take a look at some of the newer stuff out there. But as I speak, I'll always have this undertone, or we'll work with this framework. This figure is especially important to me because knowing that the average US practice runs at about $390 an hour, which equals $6.50 a minute, think, okay, big deal. Overhead is overhead. I know it's something I have to fight. It's very near and dear to me because, like I said, I only practice 2 days a week, and I have to keep my practice economically viable. In fact, my 2 days a week is really 1.5 days because my Friday is a half day. And then quite often that Friday is on the road where I am maybe speaking in a live venue, especially as those are opening up again. And so really some months it winds up being 1 day a week. So generally my work month runs between 4 to 6.5 days of productive time with patients. So every minute counts for me. And I look at a minute as $6.50. And if I misuse or abuse or waste that minute, I feel like I'm flushing $6.50 down the drain. With that said, that was pre-pandemic. I think we have to look in the rearview mirror out a few years from now and see where the new overhead is. But we know that initially when kind of the world closed on us, first we weren't doing any dentistry, just doing bare minimum emergency work. Then when we came back, we kind of tiptoed back into the waters. A lot of patients were postponing those high dollar elective procedures. There was a huge increase in overhead as it related to PPE and other costs. We were buying things to improve ventilation in our treatment operatories, spacing and gapping patients further, seeing one at a time, not seeing multiple columns, patients not waiting in waiting rooms. All these things basically went against the efficiencies that we had built in place. And that speed, efficiency, predictability is really important. We have to have outcomes that are predictable so we can reduce redos and not have repair procedures, emergency procedures, redo procedures, especially now. Before we had a little bit more room for error. Now, if we have less time to do what we want to do appropriately, the last thing we want to do is have to redo procedures on non-productive, non-billable hours. So with that efficiency and predictably in mind, we know that contemporary practice really revolves around adhesion. And this applies to direct dentistry as well as indirect dentistry. Whether you're bonding in modern ceramics, whether you are bonding in direct restorations, without adhesives, we wouldn't be able to function today. And so we're not going to go into, in a 50-minute webinar, go into details about looking at microscopic slides, SEM slides of adhesives and how they interact with the smear layer or tubules or what have you. But a quick overview is important so you can place yourself in your practice as far as where you fall within the spectrum. Over the last 35 years, we feel like we've, with the help of manufacturers and R&D, more or less perfected as well as we can the adhesive equation. We started with the first series of adhesives that were functional, and those are the 4th generation of adhesives. Finally, we had adhesives that got values up above 20 megapascals of bond strength, and these were 3-bottle systems or 3-component systems where we would use a phosphoric acid, usually a blue-colored gel etchant, onto the tooth, follow it with a primer, and then finally follow it with the adhesive. Each was scrubbed in a prescribed amount of time or air thinned a prescribed amount of time, and eventually light cured, and we were ready to go. It was somewhat cumbersome. It was a little difficult. And so with the goal of always trying to simplify procedures, manufacturers developed the 5th generations of adhesives where they were able to eliminate one component. They combined the primer and the adhesive. And so we went from a 3-component system to a 2-component system. And it also worked. It wasn't that the outcomes were suddenly leaps and bounds ahead of the 4th generation, but it was simpler for some people. And for other people, they wound up having more pitfalls. They wound up having more sensitivity. And so R&D continued. We graduated to the 6th generation adhesives where it was still a 2-component system, but now we eliminated the phosphoric acid and separated out what was in the adhesive to where we had a self-etching primer again and an adhesive step. That seemed promising. A lot of the sensitivity issues went away for science that we're not going to dig into today. But at the same time, there was some liabilities as far as the etch patterns we could get on enamel, and how good that kind of hermetic seal, our halo, our force field around the enamel was. Still, manufacturers wouldn't rest on their laurels. They jumped through and developed single product systems, the 7th generations, which are now called universals, kind of the next ancestor in that lineage. Now we theoretically have a single component, a single drop of something that we can put on a tooth that takes care of all the chemistry needs. Folks out there doing adhesive dentistry fall into a few camps as far as how they treat enamel or dentin, the substrate they're bonding to. Some use a total etch technique, some use self-etchants only and have eliminated phosphoric acid out of the equation, and some use a selective etch where they are treating enamel and dentin differently because they are different substrates. There's lots of confusion over delivery techniques. Not everybody follows the best paradigms as far as isolation. There's ongoing issues with sensitivity, and there's a challenge of how do I handle something when it's a direct restoration versus an indirect restoration. So there's still quite a bit of confusion and quite a bit of science out there that we have to really master. But generally, most of us are going to fall into two camps, either on the left side of the screen or the right side. Either we are going to do a separate etching step with phosphoric acid onto the dentin and open up these tubules. This is just a magnified microscopic slide. Those would be the 4th and 5th generations we discussed. Or we're going to use a self-etching primer, 6th, 7th generation and above, up to universals, and we're going to interact with the smear layer. You can see the dentin looks different on either side of this slide. And so when you ask a group of people, quote unquote, in the know, what they perceive as the best way to manage the dentin, manage etching, most right now are going to say the consensus is selective etch. Meaning look at the substrate and decide the strength or the pH of the acid you are going to use to optimize bonding to that substrate. Meaning we know, and this is vetted out, that we can't get predictable etch patterns to the consistency that we want with some of the self-etching primers on enamel. Still, the gold standard for treating enamel is phosphoric acid. However, we are getting more predictable, more pronounced, and less sensitive bonds when we use a self-etching primer to dentin. And so while always the impetus was to make adhesive dentistry as simple as possible, minimize the steps, minimize the time, reduce the components, really the science is saying actually it's more complicated than that. And if we always seek the path of least resistance and try to speed up every procedure and minimize the components, it actually might be to our detriment. So it does make sense to treat these two components differently, even if it means using a few different approaches to etching and adhesion. So just some general guidelines. If you follow these strategies, I think you're always going to be on high ground. Like we said, phosphoric acid, traditional etchant, is a gold standard for preparing enamel. You're always going to get better adhesion to enamel if you prepare it with phosphoric acid. Self-etching primers tend to yield the highest and most stable bonds to dentin, and they do tend to reduce incidences of postoperative sensitivity. For the highest bonds possible, there are specific two-component bonding systems that really enable us to get the highest dentin bond strengths. That being said, there are certain universal single-component adhesive systems that provide some conveniences for us, and they will get what I'm going to qualify as good, again, I'm doing air quotes, maybe not the highest, but good shear bond strengths. And so for somebody that says, I want to simplify my life, understand that we have to do everything perfectly, and we can have pretty good results, but they're going to be good. They're not going to measure as the highest bond strengths measurable in a laboratory. But either way, no matter how we look at it, poor bonds equal lost dollars. And in my opinion, the highest bond strength, the better. So for example, one of my favorite single component systems, a universal adhesive, is Futurabond U from Boco. And one of the things that gives them an advantage over some of the other universal adhesives is while it's a single component delivered out of this little foiled punch through reservoir, is that they actually keep their chemistry separate. So until you're ready to deliver, that's when you will squeeze the blister pack, incorporate the chemistry, open that up, mix it, and deliver that single product. Compared to a competitor product that might have all the chemistry in the same bottle, this tends to keep everything, first of all, sealed, doesn't evaporate. Secondarily, keeps some of the unstable chemistry separate until the moment you need it. So when we talk about bond strength, we have to look at the mechanics of bond testing, and this is pretty universally understood that there's a shear bond testing system. Ultradent Labs developed what's now the ISO standard using an Instron testing system to fracture off composite buttons and get a measurement over a defined surface area, and that would lead to a standardized reporting of shear bond strength, which we all see from the different manufacturers. They'll say that, hey, our adhesive gets X megapascals of bond strength versus here's our competitors. That's how that's done. And yet there's a lot of variability. What we wind up seeing is the compendiums of information or the propaganda or the graphs or the charts from all the different manufacturers, and understand circumstances on how it's done, the technique for how the samples are prepared, down to how a button is sheared off, for example, with a straight kind of a shear delivery system versus a notched contact. We could have two equal bonds measure very differently. So these things have to be compared to an apples to apples mechanism, and different manufacturers test differently. So it's always nice to see independent data from a standardized source. For example, the highest bond strength that I know of that's been ever achieved out of Ultradent Labs is one of their lab technicians managed to get a sample all the way up to 95 megapascals. These are not numbers we typically see from manufacturers. So here's the question. How strong do we want our bonds to be? Because when we start to talk about some of the dentistry in a second about class 5s and class 4s and some of the more challenging restorations, really it comes down to bond strength and what is an acceptable number. When I'm meeting with audiences live and I ask that question, hands go up and people will guess, well, north of 20, north of 25, north of 30. They love when companies report bond strengths in the 30s and above range because that seems good. And a lot of manufacturers will report that number. And guess what? When they show the graphs, they are always ahead of their competitors. So you start to wonder, how can everybody have the best strength and the best numbers? Well, I'll offer this. When we are rebuilding the tooth through adhesive technology, our goal would be to try to build that tooth back to its original integrity. Isn't that logical? Try to get that clump of dentin to behave as if it was never cut. It would never had caries. It was never destroyed. It never fractured. So as you're replacing the missing pieces with artificial material, composites, ceramics, whatever you're using as your restorative material, if it can integrate back to the tooth and make it seem like a seamless growth that was not too unlike materials, then that would be the best scenario. You're building the tooth back to its original integrity. How do we test that figure? What's that value? So it's pretty simple to do. Basically, here in a lab, manufacturer's gotten a block of tooth, and this isn't a composite button. They basically milled out a portion of that dentin rather than shaving it flat. So this is dentin to dentin. This is the original tooth with the nubbin left out of it. And now that's been through a shear bond strain. When we look at that number, here's what we get. The cohesive strength or fracture resistance of dentin, the average buccal lingual of molars is where you get the highest, basically approaches 100 megapascals, and it doesn't really drop much below 70 in even the weakest parts of the teeth, the facials of incisors near the cervical areas. So really, if we're trying to rebuild teeth back to their original strength or integrity, we're trying to get numbers approaching 60, 70, as high as possible, ideally approaching 100. That sets a whole different stage when you start to look at what's advertised out there. So buyer beware. I would say be very cautious about the data you see, rely on independent testing, and pick an adhesive that has the potential for great outcomes. And then after that, realize that it is in your hands. So much of its full capability, it really depends on the operator and the delivery mechanisms. Something like a Futurabond U, a universal adhesive, what makes it simple and easy to use, where we can get good adhesive rates, is that it works across all aspects of dentistry. You can use it for direct or indirect. We talked about, because it's a very well-sealed blister pack, that it's always going to have fresh chemistry. One of the big things that puts it ahead of a lot of the other universal adhesives is that it's got the dual cure chemistry built in. Many of the adhesives will say that, but when they're tested independently, sometimes we feel like they don't perform as well in a dark setting. They don't have the full conversion, or sometimes additional drops of other materials need to be added to change the pH to get them to go through full conversion. If it's an area that's tough to reach inside of deep, dark canals, underneath very opaque crowns, we do want something that's going to predictably dark cure as well as cure when it's hit with a curing light. For indirect dentistry, low film thickness is incredibly important, because if you're curing your adhesive before you cement your crown inlay, onlay veneer, if it pools and changes the dimensions of your prep or the substrate, now your indirect restoration is not going to seat the same way. And of course, like I said, fast to me is not worth it. But of course, given the option, I'd rather it take less time than more time. But that, again, the caveat is, if you need to spend 3 or 4 seconds longer to get a successful bond, that's well worth it, because when patients come back for 15 and 20-minute visits, they can't be charged because they have sensitivity, or a crown has come off, or a composite is broken away. Those are far more devastating. You know, losing 10, 15, 20 minutes, 30 minutes, having your whole day fall behind at $60.50 a minute is not worth saving 5 seconds on the delivery end. So we are looking for things that are truly universal, and so that we don't have to keep multiple products in the office. We can deliver all the dentistry that we need across all materials. So what's the reality in practice? What are the restoration types that we do? This is roughly how we break them down. Almost half of the restorations are traditional class 2 restorations, MOs, DOs, MODs. That's probably not a surprise. Almost another quarter are the class 1s, posterior teeth class 1s. So approaching 70% of restorations with composites are going to be class 1s and class 2s. That's why so much time is dedicated to these specific techniques and restoration types in the CE arena. Doctors always have challenges with class 2s, and we can touch on them a little bit today. But today I wanted to make this a little bit more unique, and so we're going to spend some time on some of the other pieces of the pie, the more challenging restorations that are sometimes not spoken about as much, because they can be incredibly frustrating when things go south on us. We'll specifically give some time to class 4s and 5s, because those tend to be restorations that, if we don't do everything right and don't have the highest bond strengths, they tend to have more premature failure, lead to more redos and more inefficiencies in practice. Let's face it, a class 2 that has a wall on every surface, into the box, on the buccal, on the lingual, pulpal, axial, unless you're at placing the restoration with something that doesn't stick, unless you're using Vaseline for your adhesive, they generally don't fall out. Now, if we've done the adhesive step poorly, they tend to have premature failure as a result of leakage or recurrent decay, sometimes sensitivity, and all those things are bad, but you don't have immediate catastrophic loss. With a class 4 fracture on an incisal ledge, we can have immediate catastrophic loss. So let's look at one of those. And this is common. Every day in our offices, we see things like this. Patients come in and they say, look, edge of my tooth broke. It's a little rough. It's in the front. It's right in the cosmetic arena. I don't like the way it looks. Please fix it for me. And this is our chance to look like a hero, because we are very good at putting a little composite there, bonding it on, giving the patient a mirror, and suddenly you're the all-star. This is great, doc. I love my new filling. It looks beautiful. You did such a good job. That's why I come to you. The most amazing dentist I've ever had. And notice, I love my filling is what they say, because whenever they like something, it's theirs. When they show up on your schedule 3 months later, doc, your filling fell out. Now it's not theirs anymore, it's yours. They're not happy. You're not happy. You're just about to spend another 15, 20 minutes trying to eat crow, try to explain away why it came off, try to put the blame back on them. What did you chew? Did you chew on ice? Were you chewing your fingernails again? Did you open up a bag of chips with your teeth? What are you doing wrong? I did the best job I could. I'm going to do the best job I can again. But if this ever breaks again, we got to do something else. Why would we want to do something else? This is a near virgin tooth. Last thing I want to do, because I can't get an appropriate bond to that edge, or I keep having to chase my tail restoring this and repairing this, do I want to waste away all this lovely enamel, shave it away, and deliver a difficult to match lab veneer waste tooth structure just under the premise that this will be stronger ceramic that now is bonded to the entire surface? I would love to be able to restore this with a direct restoration and get the patient years and years out of it. At a minimum 5, but ideally 10, 12, 13, 15 maybe. Is that reality? It isn't for a lot of people. But again, we go through the techniques that we were taught. You can see that there's a little bit of beveling that's done. There's a mylar strip in place, some phosphoric acid, because we said phosphoric acid is the gold standard to treat enamel. Apply our adhesive. Apply a few, sometimes one color composite. Sometimes if we look at the characterization in the tooth, and you can see those teeth have they have some translucency, some opacity, some marbleization in them. Might need a few different shades and a few different opacities. Slowly build that tooth. And at the end of the day, if we do a good job, this is when your patient loves you. Done a good job. When it keeps breaking, they're not quite so happy with you anymore. So let's look at a case. That just goes from start to finish, but I can assure you that all of us, myself included, have been frustrated when those little repairs fall off. And I have had cases where I've repaired them 5, 6, 7 times. And at one point I had to ask myself, wait a minute, is this repairable? Is there a way to do this better? Am I missing something? So to go through that detail, I'll share this example with you. This is one of my former students. She graduated maybe 3 or 4 years ago. Came to me one day, and this young female had gone through some aesthetic courses and was being critical of her own smile. Said, yeah, for my age and demographic, I would like to show a more toothy smile. I want my teeth a little bit longer. Dr. Hakeem, I have just finished Invisalign, and my ortho resident is going to scan my teeth to plan my refinement. There's a few areas we want to fix, but more importantly, my concern is how much incisal display I have. You can see these little chips that I have on 8 and 9. I would like you to fix those. I said, okay, that's not so hard to do. We'll try to do a good job. He goes, but that's not where I want to stop. I not only want to fix those, but I would love for you to extend these teeth, make them about 1.5 millimeters longer, because look at this smile. I would like to show more teeth, and my incisal edges don't quite come down to my lower wet dry border of my lip. So what I'd like for you to do is give me a toothier smile, 2 longer central incisors. And when my ortho resident plans my refinement, they are going to put attachments on the remainder of my anterior teeth and pull down my laterals and canines to match the new length that you've established. We're going to kind of dust the edges of these lower teeth and get them a little bit better aligned where maybe I'm not tracking as well. And now I'm going to have the smile that I've always wanted. And at that point, I said, you've got to be crazy. You're telling me that you want to develop 2 long Bucky beaver teeth. And those are teeth that are fractured before. Now they're going to be the only teeth that are going to hold your protrusive guidance as you go forward multiple times a day, or as you grab aligners and pull aligners on and off. These are going to be incredibly stressed teeth. And it's going to be egg on my face if I add 2 nice restorations there that break off within a month or 2. So she said, no, I'm confident you can do it. Let's do it. That's going to be how we're going to set the stage for my new smile. And she slowly kind of wore me down until I said, okay, if we're going to do this, we're going to do it without any guarantees. And we're going to do it in a way that we get some learning to happen. So we're going to photograph each stage, and you're going to get some of your classmates involved. And eventually I relented, and we decided to start. First step, I told her to take an impression and do a wax up. She tried to convince me to do the wax up. I said, no, you're doing your own wax up. So she did a wax up of what she was hoping her new incisal length would be, what the edges would look like. Got a little feedback, adjusted it. Once it was done, and many of you know this technique, we basically make a putty matrix that we can cut that winds up being a tight-fitting lingual putty matrix that defines the incisal ledge and the lingual anatomy. When we go to the mouth, we can put this putty matrix inside the mouth, and basically, if the impression was accurate, then the putty is going to be accurate, and it just shows exactly where our areas that we're going to add to. It gives us a matrix where otherwise it's very hard to develop this contour and shape. If we try to just put a mylar strip between these teeth, those become very kind of mechanical and rounded. They don't look like teeth. We wind up having to over add and try to carve back and make the restoration look like a natural tooth with rotary instruments, which doesn't always work out. So we would like to have some kind of an aid or an adjunct to make these teeth look as naturally contoured as possible from the beginning, minimize how much finishing with rotary instrumentation we need to do. So there's that putty matrix in place. You can see what a tight fitted against all the other teeth. And so it gives us a very good scaffolding to build our composite up to. Incidentally, this is an Optrogate from Ivoclar. It's useful for anterior retraction. I will wind up using an isolite in the back of the mouth to help with retraction. It's not always easy to fit these putty matrices with rubber dams in place, so I wind up using the isolite system quite a bit and have gone through quite a bit of testing to understand that it does a very good job of isolation, equaling, if not beating the rubber dam on that, and that's also a good subject for another day. But anyhow, between the isolite for moisture control and this Optrogate to keep the lips out of the way, it makes for an easy work environment. It also allows me to not have to put photo retractors in and out. I can stop at any moment, take a photograph without things collapsing onto my working field. Now, I go through a few extra steps here. With a case like this, where I know adhesion and bond strength is at a premium. Again, this is not a typical class 2 restoration sitting with walls all around. This composite is going to have a small bit of surface area to bond to, and those teeth are going to be under protrusive stress every time that patient bites, chews, grinds forward, any kind of parafunction, anything. And so while I don't always get pumice and a prophy cup, I said, hey, here's a chance where I need to remove any surface biofilm. This is pure flour pumice. This is not fluoridated pumice like prophy paste. And I'm just going to clean well beyond the borders of where I'm going to bond to. Just a good habit to get into, especially when the highest bond strengths are paramount. Next, I'm going to get just kind of a medium grit diamond burr, and I'm going to scour the entire bonding surface beyond where I actually think my fracture or my restorative repair is going to land. So I'm going to, if this is the area I'm adding to, I'm going to go a few millimeters past that. And all I'm going to do is just roughen this up to increase surface area. This is macro mechanical. The smaller or more dramatic surface area increase is going to come from when I etch this. Then I get some flame diamonds, and I know the flash kind of might distort this a little, but you can see I've started to put this very irregular or erratic bevel in place. That's my next strategy. This is not at all uniform, and these bevels will spike up and down different lengths and widths into the incisal edge of that tooth. There'll be a little bit of adhesive and composite that's actually going to go right in between the embrasure, and that area I haven't been able to instrument. So often I'll roughen that up with a little sandpaper strip as well. So basically, I'm getting that entire tooth ripe for bonding. This helps visualize it a little better. This is just a typodont for one of the hands-on courses we do where there's actually a bigger fracture, and you can see this irregular, erratic bevel, how the spikes are different depths and different lengths into that enamel area while the entire surface has been roughened up with a diamond. That's what we mean by an erratic bevel. And it's more critical for me to have this on the facial. You can see that on the lingual of the tooth, I didn't bother putting in an erratic bevel. I can just put a standardized finish margin, maybe a 45-degree bevel there. Now, I don't often break out the air abrasion unit. In fact, we have one in the back of the lab where we want to instrument zirconia or clean out crowns that have cement in them, things like that. But we do have one convertible to chair side. And again, everything hinged on the best bond strength possible. So I'm going to air braid with aluminum oxide the surface of these teeth far beyond where my actual finish line, my approximate finish line is. And what you're going to see is here is a tooth. Now the putty matrix is back in place. I have a little bit of Teflon tape or plumber's tape against the adjacent tooth. This is probably vaguely where my infinity bevel, if we want to call it, is going to contain restorative material and adhesive. But you can see how I've finished the tooth, gotten it ready and ripe for bonding beyond where my perceived margin is. And that's very critical. We don't want any adhesive on an area that maybe wasn't prepared to bond correctly. And now, again, like we said, this is enamel. So the gold standard for enamel is again phosphoric acid. And this is how I maximize the surface area and get the right etch patterns on the enamel. I'm going to wash that away. And again, enamel is different from dentin. If you're using phosphoric acid on dentin, generally you're around 15 seconds at a minimum 12, but you don't want to go much more than 15. On enamel, I'm comfortable putting that phosphoric acid on for 25 to 30 seconds. That's thoroughly rinsed away. We get the enamel not completely desiccated, but it's okay for it to turn a little chalky, completely different with dentin. We don't want to overdry dentin or desiccate dentin. And then we'll go ahead and place our adhesive, scrub that for the prescribed amount of time. I can't emphasize how important that is. If a given manufacturer says scrub for 15 seconds, that's what you need to do. If they say 10, that's what you need to do. They've tested all this, and those timelines matter. And typically, I see dentists usually subtract about 75% of the time. To them, they have a very fast internal clock where 10 seconds equals 3 seconds. Same thing with air drying. The direction, the angle of the air, making sure that it's clean air with a filter that doesn't have oil or water sputtering. If it says start with a mild air stream and then slowly increase the pressure, if it says aim directly at 90 degrees versus an angle, all those things matter as we evaporate carriers and we thin that adhesive film. Getting that film of adhesive to the right thickness or thinness is very important. Getting the materials that we don't want to evaporate out of there is very important before we hit that with a curing light. Once that surface is cured, now we've turned our attention to the putty matrix. We can actually do this in advance, preload it with composite and put it underneath a dark cover so the light doesn't prematurely set that. But we start to shape the anatomy that's there, form kind of the developmental lobes and mamelons with the different colors that we want. We can use a little bit of flowable to marry the edges. Carry this to the mouth, seat it in place, use an explorer or some kind of an instrument to really kind of fuse or gel it with the lingual aspect of the tooth and light cure that. Now we've built a very anatomically correct lingual shelf, and we can go back and backfill this with composite. Often I'll use one of these Cosmodet brushes to really refine these sable brushes to refine my final layer of the composite addition on the facial aspect. And I basically built this tooth from the lingual outwards to the incisal edge and to the facial, trying to do a little curve on the proximal, get the right shape. And once that's cured, we go into finishing. So carbide burrs tend to leave facets that are easier to polish. Diamond burrs tend to leave more matted finish. At the end of the day, diamonds are sometimes more effective. Carbides lead to a better polish, although they could have more chatter. So people have their favorites. If I use a diamond burr, I typically follow up with a carbide multi-fluted burr. And certainly we use discs for a lot of the embrasures, and we can use some of the sandpaper strips to get to the proximal. So here's a tooth with my initial pre-finish. This is not fully polished. This is pre-finishing and shaping. Then I'll go to my next set of grits. So these happen to be Opti discs from Kerr, the really fine discs with the finest kind of grit to them. And I wind up using quite a bit of these wheels, these more modern versions of the wheels that look like almost car wash chamois, where they have facets and flutes and are flexible. These happen to be the ASAP, stands for All Surface Access Polishers from Clinician's Choice. Ultradent has a similar product called the Jiffy Naturals, and they have a pre-finish and a fine finish. And this satisfies almost every polisher finish that I need in the mouth. Sometimes I will get these very stiff, Jiffy brushes, especially in the anterior zone, and sometimes add a little bit of diamond finishing paste. Those are pre-impregnated. And with a lot of pressure and stall out speed, I'll give the final bit of finish with that as well. But often you can end just with this finest silicone, and you're going to have a very nice high shine finish. So one of the things that I want everybody to notice is, while this has been a little desiccated because there was an ice light running in the background for much of the procedure, do you see how nearly impossible it is for you to see where my finish line begins and ends? That has to do with that erratic bevel that we placed and how that masks from the viewer, from the eye, where that otherwise more visible regular finish line would fall. Finish lines and restorations that you can see sometimes confuse us because we look at it and say, well, I could have swore I chose the right color. Why is that visible? Am I missing the opacity? What's going on? And the reality is, no matter how good our composite products get, unless we get the exact same relative light penetration or reflection that we're getting from the native tooth substrate, sometimes we'll see that finish line even though we've chosen the right color. Even though there's no shrinkage, there's no gap, there's no barrier in between there, we can just see a little light diffusion difference. If we create that erratic bevel and there are fingers of composite resin that are projected at different depths and different heights into that tooth, it completely blends our finish line and makes it very chameleon-like where it disappears. So at that point, we basically repeat the steps for the other tooth, number 9. And here's our 2 products at the end. A lot of times black and white photography is nice because it'll show you kind of the value equation. You can see we have a little bit more opacious composite that I put on number 8, less of that on number 9. I try to create some irregular kind of jagged edges and more of a youthful look with mamelons. And so she got what she wanted. The teeth are longer. She's got a template or a roadmap to pull the other teeth down, increase the appearance of her kind of toothy smile. But none of that matters because everything might look pretty okay at the beginning. What really matters is if she comes back to me with these composites in hand, 3 months later, 6 months later, saying, remember the fillings you did? They've broken. That's a very frustrating day for all of us. Good news here, we did this procedure, I'm going to say 4.5 years ago, maybe 5 years ago, and I was curious to see how it had gone. I ran into this colleague of mine maybe a 1.5 years ago at a meeting in the Sacramento area, and I said, well, let's see, how did the refinement go? How are your teeth? Are my fillings still there? And she said, well, just like typical dentists, I'm the last person, I got busy with work, the last person I thought of. I wasn't very gung-ho with my refinement. I'm just starting it again now. So she dropped the ball, and that scared me because that means that those 2 teeth were longer than the rest of her teeth. She didn't have shared guidance, shared protrusive load, and wasn't wearing aligners at night, maybe to block some parafunction or so. And so I said, well, are they still there? I was dying, anticipation. She smiled and proudly showed them, and really they looked pretty darn close to what they looked like day one. So the proof is in the pudding. If we go through and treat the enamel correctly, use the right adhesive, use the right techniques, we can get these very high-risk restorations that last a number of years. For folks that are curious, the restorative material there was Admira Fusion. It's a composite by Boco, and it's an Ormisor product, which stands for organically modified ceramic. It's the only resin on the market that has a ceramic kind of substructure to it and has tremendous biocompatibility in the sense that we have very complete conversion when we cure this, and there's no free radicals left. There's no composites on the market that pass FDA that are unsafe for patients, but especially in the area that I work in, there are patients that are a little bit concerned about what's in resins, BPA, things like that. And so especially for that crowd, this makes a very easy answer. In addition to that, it's one of the, I don't want to say one of the, as far as I know, it's the lowest shrinking composite on the market. And we know that composites have really been perfected over the years. Anytime we have resin, we're going to have shrinkage. And that was one of the big concerns with composite resin is composite resin shrinkage and shrinkage stress. Most manufacturers now have their resin shrinking sub 2%, which is great. But in mirror fusion is all the way down to 1.25, which is the lowest shrinkage rate that I know. And so that's another reason why this is one of my preferred materials out there. So that begs the question, what composite should we use? And I'm here to tell you that as long as you're using a contemporary composite, one with modern science behind it, that has nanoparticles, a lot of it comes down to your preference, often with handling and aesthetics, and just what works well in your hands. There's lots of good composites out there, but at the same time, if you're looking at your composite reorder and it's the same thing you've been ordering for 20 years, and it's on auto order because your assistant or front office orders it, there are better, more innovative products out on the market. And so I think every so often we owe it to ourselves and to our patients to put the best products in our hands and in their mouths. So I can sit and talk a long time about my favorites. You've seen a few of them in use. But what I'd rather do is maybe look at the techniques behind it and share this with you. I think it's more important to have a variety of viscosities in your practice. That's how you become more capable of doing the best dentistry possible. And I'll focus less on the brand names, although I certainly have my favorites. So depending on the clinical circumstance, the given shape of the prep, the kind of load that's going to be brought to bear on that tooth, if we expect that tooth to flex, if we think there's going to be some adaptation and handling challenges, if that tooth is right in the front window where it's a high aesthetic demand versus way in the back of the mouth, if there's difficult access, if we've done a more kind of conventionally minimally invasive dental preparation, modern preps that conserve more tooth structure, means that it's harder to get certain composites to the bottom of a really skinny, narrow box, for example. All these things have a ideal answer when it comes to viscosity. And I think a practice that's using a single composite with a single viscosity probably is going to have some challenges. They're not able to deliver the best dentistry possible. So sometimes viscosity matters, and often I'll use combinations of viscosities to get my best results. So that being said, the next natural lead-in is that I really, really highly rely on flowable composites. And I think Voco has some of the best lines of flowable composites out there. I use their Grandioso flow quite often. This is their standard kind of mid-level flow. They have a light flow, which is more runny, and a heavy flow that I use often as well. This really stays put. You can kind of cone it up like an ice cream cone. It does have that flowable creep factor, so it really adapts to the substrate, but it doesn't run out of the page per se. So depending on the direction the gravity pulls the composite, there's times where we don't want it to run away, and something that behaves somewhere between a flowable composite and a body composite is ideal. And certainly they have bulk fill variations of this for insides of boxes below a capping layer. So with that said, we can talk a little bit about class 5s, and we'll end on this subject. There's a lot to talk about behind the science. People debate on whether, we know when there's caries. Caries class 5s, we know how they got there. But then there's all these terms that are constantly evolving. An older term we used to use, abfraction lesions, which was a made-up term. And it was something that Grippo first described about the concept of tooth structure breaking away as a result of flexural stress. Now the more conventional term is NCCLs, non-carious cervical lesions. Abrasions that Dr. Abrahamson discussed having to do with toothbrush abrasion, but only when it's used with dentifrice. Really coarse toothpaste could exacerbate that abrasion. We know about erosion, chemical wear. Is there a link to parafunction? Is there a link to sleep disorders and apnea? How does diet play a part? Reflux, people on multiple meds, just an acidic environment, whether it's external or internal, all these things tend to lead to these NCCLs, and we sometimes struggle to come up with the exact etiology. But at the end of the day, and here's a couple of studies that you guys can take a quick picture of and might give you a quick read and a chance to review with some of the contemporary thought processes about the etiology of these things. At the end of the day, We can talk all about the etiology, and it's great to get to the bottom of that because you can start to put preventive tactics in place for your patients so that they don't develop new ones. But what about the ones that they have? Should we restore these? That's a big question. And it depends on who you ask. Some folks say, no, if it's not hurting the patient, there's no problem. Let's not restore them. My answer, and I rarely say always, so I'm going to say almost always. My answer is that we should almost always restore these. Like anything in dentistry, there's always exceptions. But when we look at these things, based on the shape, based on how shiny they are, based on the way the cleft is, based on where the teeth live, we can get some clues as to what the etiology was. But no matter how they got there, at the end of the day, patients aren't born with these giant clefts out of the teeth. And we can see small ones become bigger ones, become bigger ones, and become bigger ones. And often they're multifactorial. But why are we sitting here chaperoning these teeth, getting further and further along the destruction spectrum where we can restore them? It just doesn't make sense. Well, here's why. If a patient isn't complaining about this and it's not in the aesthetic zone, and the doctor restores it and has bad luck with the restorations, they would say, well, okay, I'd rather wait on that, but maybe this one's hurting the patient. I'm going to wait for them to get that big before I restore them. I don't think that's the smartest strategy. And I'll use this analogy. What if you went to your cardiologist and the cardiologist said, you know what, I just did an angio and it looks like one of your vessels around your heart is only about 30% occluded. And that's not all that bad, but I'll keep an eye on it. And when it's about 70% clogged or blocked, we'll go ahead and treat that. Would we ever accept that from a cardiologist? Absolutely not. So why are we accepting them from ourselves? Why do we say, let's chaperone your teeth getting worse and worse, and let's wait till it's the point of no return before catastrophic changes happen, and let's restore them then? It just doesn't make sense to me, because then in that process, sometimes we're restoring them with very extravagant crowns and more invasive restorative procedures. And a lot of times these are right in the front window where patients really care about the aesthetics. So if nothing else, they want their teeth to look more normal. They don't like the fact that they look long and they have these clefts to them. So a lot of people don't restore these class 5s because they look at it and say, hey, look, after a couple of years, you know, they're getting a little deeper, but look, I did some here and there's some stains around them. And sometimes they look a little worse. And sometimes they look really bad and have recurrent failure and decay, and it's obvious where the restorations were. And I can't blame folks for not wanting to restore these teeth, because if this is what we're getting in the short-term outcome, then we should leave them alone. Our axiom is to do no harm. If I'm putting a restoration on a patient that is only going to leak and lead to a bigger restoration and a bigger problem, then maybe the path of least resistance or the smallest error is to leave it alone. But if I get to where I'm competent at restoring these, not having outcomes like this, but hopefully outcomes that look better and retain tooth structure, then, you know, it might be a good idea to restore them. And I will say that I restore almost all of my class 5s almost exclusively with flowable. Again, I'm not going to say always, but I'll say almost always. This surprises some people, but the rationale is that I get much more precision placement. The load demands on the cervical aspect of the teeth are different. They're not an occlusal function. However, that's where teeth flex. And flowable composites, by definition, because they're less filled, have a flexural modulus more similar to natural tooth. So in that aspect, as a tooth flexes, they can flex with it, and they're less likely to pop out as a result of that flexural stress. And I have a way of delivering these where I can decouple walls and neutralize the biggest effect that we're concerned about with flowables. Because they're less filled, they're going to have slightly more shrinkage stress. We know how to eliminate that, almost virtually take that out of the equation. And I can be very efficient in placement time. And that efficiency winds up leading to much quicker finish and polish time. Reduction in rotary instrumentation, where we don't want to go in and damage and beat up and batter the remaining dentin and the cementum below the finish line. So we can get very good aesthetics, very predictable results. And my definition of success is that I can place one of these class 5s quickly, efficiently, often without anesthetic, And I don't want to deal with it for another 6, 7, 8, 10, 12, sometimes 15 years. That should be what we can expect. So let's look at a case we just did on a typodont so we could videograph this. This was shortly after I had shoulder surgery last December. So I was incapable of working on patients. I was just starting to get my arm out of a sling. So I'll apologize for some of the shakiness in the hand, but I wound up kind of cheating a few weeks early. My orthopedic didn't know. I got my dominant arm out of the sling and we kind of filmed these, or my office manager filmed it as I did it. So first we got to type it on, and we just basically hacked out a class 5. I would call a medium-sized class 5. We know some of them get bigger than this and certainly some are smaller. Just created a fake class 5. I didn't go right to the gum line, although many of these do, because I didn't want to destroy the typodont gums here. But here's the biggest thing. Remember, anytime we do this, I'm going to always roughen up the dentin. Often there's sclerotic dentin. I'm going to go in there and abrade that with a little bit of a rounded diamond, just to freshen up and get a new layer, not to bond to any contamination, any biofilm. If you have an air abrasion unit, you can do that. But more importantly, look at my enamel margin. You'll see something familiar. There's my erratic bevel. You can see these little bevel areas. It's not a standard monoplane 4 to 5 degree bevel like we were taught. This is an erratic bevel, and I'll give you a view from a different angle as well. You can see that they project up at different depths and different lengths. And here's another view from the side. So it's hard to see this because this is white background on the tooth, but hopefully you get a good picture. And I do this routinely. The amount of tooth structure that I'm wasting is minimal. And what I do is wind up having restorations that don't need constant repair and adjustment. So in the long run, I wind up saving tooth structure, more importantly, creating an aesthetic appearance that becomes virtually invisible. I hate it when I can see my class 5s. I want the patients to look at that and say, oh, looks like you never worked on the tooth. Did I really have a lesion there? So we'll play this video. And here is some grandioso flow. You can see, and sorry about the shakiness again, this is the arm that hasn't been in use for a couple of months. You can see that I'll put a thin layer of flowable composite only on the gingival floor. And I'll use an explorer and tease that right out to my cavo surface. And that's it. You can see that that composite is not bound to any other wall. Meaning when I hit it with a curing light, and I'll fast forward for the sake of timing here. When I hit it with the curing light, it's only shrinking to that one wall. There's no shrinkage stress pulling it away from that wall or from the adhesive. Then I've added the next layer. These are, imagine this is half of a pie is the lesion, and I'm adding slices of pie back to that to make it a whole pie. So the next layer just gets teased over the original layer, dragged out to the cavo surface. Once again, that's cured. And you can see this viscosity, whether you're using the medium flow or the heavy flow, is not running away from me. It's only going where my explorer tells it to go. Rather than putting a big dollop of body composite that then I have to smear and butter into place with a composite instrument, often excess goes on the gums. So you can see of a lesion this size, and I'm going to break that into 4 or 5 or 6 additions. Now, each time I add a little bit more, the previous layer has already shrunken back to its original wall. So there's never this bridging of 2 millimeters composite in one go from the occlusal wall to the gingival wall, bound to both walls, which would then lead to tremendous shrinkage stress on a flowable composite that's not going to be down to 1.25 like we talked about the body composite. It's going to still shrink in the 3% range. And that's where the shrinkage stress becomes something that can overcome your adhesive strength. Now at the final layer, now I'll just fill in whatever areas I think are under contoured. I'll drag this, all the composite below it is already shrunk. I'm basically going to feed this into all my margins, make sure there's no voids. Pull it into all of my occlusal beveling and incisal beveling. I can see I'm a little short some of the areas of the erratic bevel still were missing composite. And my goal here is to deliver a composite that gets back to the exact original contour and size of the tooth plus 3-4%. That's it. I'm not a big fan of overfilling and then carving back. So here's a view before polish. You can see how this tooth is only slightly more robust or more bulky, has a broader height of contour than the previous uncut tooth surface. I leave myself very little finishing to do, and I have no material going into the gums or into the sulcus. So then with a few passes with a rotary burr, I quickly get that down to its original contour and a very good finish. So here's a few different views. Now I purposely, for this demonstration, I use this, let's call this Typodon tooth an A2 shape. I purposely used I think this was an A4, a very dark color, so that you can see the difference in this black and white photo at the gingival aspect. This is never a color we would choose for a tooth. If it was A2, we would select A2. But look at the occlusal side where I had that erratic bevel. See how well that disappears. Even with a shade that's 3 to 4 shades off, I almost have that disappear. That's where the magic of that erratic bevel is. Yes, you should always try to get the right shade, but if you're even in the ballpark, when you put that erratic bevel and you have light going through those finger projections, hitting natural tooth structure and rebounding down, you will have virtually indetectable margins to the naked eye, rather than seeing a nice tooth line and a nice composite line and saying, okay, there's no decay. I think I chose the right color. And yet it jumps out at me. I can see my class 5 restoration. So that's really the big benefit of that, is trying to get a really well-polished, easy to finish restoration that disappears. And of course, the magic is in how well the adhesive layer adapted and the strength that's there. I'll show you a quick case. This is a full mouth rehab where it's largely crown and bridge, done by my junior associate. I just helped quarterback the case. This was Dr. Nishioka, but at the end of the day, almost every tooth in this patient's mouth had crown and bridge and veneers, shy the front 8 teeth, tooth number 20 through 27. And this patient was a tobacco chewer, had some class 5 cavities and old restorations that were leaking. And her final restorations in place here. That's a good topic for another day for a crown and bridge course. But now you can see through this same technique what this looks like after a 3-year post-op, where you can see these margins and these class 5 restorations from here to here are virtually indetectable. So if we can deliver this, then yeah, absolutely, we should be restoring these. We're saving the patient from more damage. We're covering up that vulnerable dentin that's vulnerable to acid erosion, more decay, all the issues that we have. But of course, if that's our outcomes, then I don't blame people for not wanting to restore these. I think if we can up our technique, up our delivery, we're doing one of the biggest favors possible for our population to restore these. So at this point, we've gone all the way through the full hour. So I'm going to just quickly fast forward through a couple of slides. I had some more content we can save for another day. And I will say, when a product or technology or technique can afford you the chance to improve quality, predictability, speed, all this stuff, where you can do things not only better but faster, that's kind of a reverse paradigm. Usually in dentistry, something that's faster usually means a shortcut or lower quality. We've shown you a few things that I think we can help you do faster but improve the quality and outcome, and I think we should always try to capitalize on that. So with that, I will thank Viva and Voco. There is my email as promised again. I will let Trung take over, and I will look at some of the Q&A. So hopefully I can answer some questions for the folks. Thank you, everybody, for attending. All right, here we go. From Dr. Freeman. Instead of using a putty matrix on the centrals, how about using a suck down clear acrylic splint so you can check the proper seating of the splint? Very good answer. In fact, I use suck down splints often, whether it's for provisionals or as reduction templates, or often for increasing VDO temporarily with composites on the back, because I am going to adjust the occlusion. No matter how good the suck down machine is, because the splint doesn't adapt to the tooth or the model that we made it on as tightly as putty or PVS, it doesn't give me that seamless connection to the lingual. Plus, I want facial access. So if I want something clear, I will occasionally actually use clear transparent or translucent VPS material, bite registration material, but I find that works better than the suck down splint. I think suck down splints have a lot of benefits for us in dentistry, it's not my favorite thing to use in the anterior. Next question was, what composite did you use? So I showed a few cases for the incisal rebuild on that patient where we lengthened their centrals. That was the Ormisser composite Admira Fusion from Voco. For the class 5 flowable, those were the Grandioso flowable lines. And the two that I would recommend for class 5s are either the regular flow or the heavy flow for the larger restorations. For class 5 lesions, I tell patients I can replace your bonds, but not your root surfaces. Exactly. So where the class 5s extend, they extend up into the enamel margin as well as down onto the root. The root is basically could have cementum on the outside and has dentin internal to that. And if we get a very good dentin bond, what I'm proposing is that we are basically cohesively growing that dentin back at a tenacious bond level to where we actually are restoring those roots. And so, you know, I tell my patients that this is better than the alternative, which is having a vulnerable lesion open that can now get further worn, eroded, deteriorated, decayed, sensitive, all the above. So what is the advantage of using flowable composites on class 5 lesions instead of glass ionomers or resin-modified glass ionomers, things like the sandwich technique? So in general, and lots of the evidence will vet that out, composites are more durable than glass ionomers. That doesn't mean that the glass ionomers or the RMGIs don't have a place in dentistry. You're not going to get the same long-term durability, the same aesthetics, the same polish, the same precision and placement. So for a population of patients that come in, that you treat, that you can surveil regularly, that you know you can control their hygiene and things like that, composites far surpass GIs. However, when you have a population that infrequently comes in, has rampant decay, you have things to deal with like polypharma or somebody that's gone through cancer therapy, has a dry mouth, you have root decay in areas that are hard to isolate, by all means, something that has some benefit in the bioactivity, to me, that's a known sacrifice. I give up something as far as control, aesthetics, polish, durability, and I gain something as far as predictability. Let's say I'm somewhere doing some mission work and there's a population that has class 5 lesions, and the next time they see another dentist, maybe 3 years down the line, 100% I would rather put something bioactive. My biggest concern in that case is not how glamorous I can make these restorations look. I think that was the last question. So I will remind you guys of the quiz to take at the end to get your CE credits. Thank everybody for their time and hope to cross paths soon, ideally in a live lecture. Thanks again to Voco and Viva. My email is there. Hope to connect with everybody very soon. Bye now.